Welcome to the Brilliant Board Review Podcast, your trusted source for high-yield board prep, CME, and the latest in clinical medicine.
Now we're going to talk about iron deficiency. And you think this would be so easy. I mean, you take iron, but our body has so many regulatory mechanisms, and even getting the diagnosis of iron deficiency isn't that easy. And we'll talk, it's a simple but complicated process. Did you know that about 50 to 70% of premenopausal women have iron deficiency? So what do? It's hard. You got to be in the room. You got to talk to them. You got to get a good history. You got to say the length of the cycle, how many pads or tampons are using. You even have to get into the level of, do you change your tampons when they're just slightly soiled or fully filled? Those kind of things. Those are those tough questions that you have to ask as a provider. So what are we looking for? We're looking for low hemoglobin, of course. MCV, usually less than 80. And ferritin. Well, ferritin's not that easy to measure too. And you're going to have, it's a Q-phase reactant. And what they're looking for too is usually MCG less than 20 was before, but actually people were in the hematology world asking for looking at MCG for deciliter less than 30. 30 is what they're looking for. And if you happen to be treating a patient with restless leg syndrome, really recommend getting the serum ferritin greater than 75. Now, this is expert opinion and this is not gospel, but expert opinion. Also, things you could look at if there's a reticulocyte count less than 2%, kind of looks towards anemia. If it's greater than 3%, look at hemolysis or bleeding is the answer. And you say take oral iron. Yes, it's simple, but not. Now, oral supplements, if you could take them with meat, if the patient is eating meat. Now, if they're a vegetarian diet, they really probably need to consider oral supplements. And I know this is old maxim, remember Popeye, eat your spinach, you get your iron. But spinach contains oxalated acids and iron absorption inhibiting factors that can chelate iron. So spinach really isn't a great source for iron. Now, what can you start off with? There's so many different supplements, and they literally change daily. And you can get the doctor's blend, and you can get this buddy's blend, and this guy's blend, or president's blend. It doesn't matter. They have all different things. You may want to try ferrous sulfate. What's the side effect? Usually GI disturbance, constipation being the big one. If that doesn't work, you can try ferrous gluconate. Is another option. Now, do you add vitamin C? That's very controversial. People say, but if you can take the iron supplements with a meat, it'd be even better. Now, originally, and you may go back to your textbooks and they'll say take a TID dosing. No, it's been found that TID dosing causes side effects. So taking it 3 times a day can cause side effects, but not really increasing your levels of iron. Taking it daily is probably better. Now, you can see that there's alternative dosing, and there's a lot of that you take it every other day because your hepcidin levels increase for 48 hours after taking it. But it's been proven in some studies is that if you take it daily, it just basically that slow but steady will basically increase it versus alternate day dosing. Plus, it's really, really hard to schedule alternate day to get those pills laid out every other day. Some people just forget it. So then if they cannot tolerate oral iron or for whatever reason cannot take the oral iron, let's talk about the IV iron. Now, before in the past, it's like, oh, no, you don't take IV iron. But man, it's becoming more and more. And you talk to your patients, and if they're having true iron deficiency anemia, and they get 1 dose of iron, they'll literally tell you while they're getting the infusion, they just start feeling this blast of energy. They feel like their old self again. So these are things to think of. And then when we're doing IV iron, in the past, it was the side effects, and the big side effects was anaphylaxis. But that really has changed with these new formulas. The big side effects is the cost. And then there's a whole bunch of different formulas that you're going to see. The main one you may want to consider based on what you have at your system, and we're going to say the dirty word cost, is low molecular weight ionodextrin. You can get a single dose. Remember, it's hard to get these dosing of 1,000 milligrams, and it's over an hour, and it's the least expensive. You can also consider fermoxetol, and this one is a 510 milligram first dose and a second dose within 3 to 8 days later. Now, the really interesting thing is it can show up on an MRI contrast. As MRI contrast can kind of screw up MRI, so you need to talk to your radiologist if you're giving this, or if you gave it so they're aware. And here again, it has to get a second dose. The next one could be ferric ferric carbomoxytase, and this is 750 milligram dose times 2 doses. This one can have almost a life-threatening hypophosphatemia, and this one's kind of going out of favor because of that severe hypophosphatemia. Next one would be ferric derisomaltase. It's a single dose infusion, and it's the most expensive. So that one you probably will have to stay away from, and we have to say that dirty word insurance. Now, if somebody's having a reaction, what's the first thing you do? You stop the iron infusion, kind of see how they're doing, assessing. Remember, if there's anaphylaxis, what do you have to do? Give IV epinephrine. Never, ever give diphenhydramine or Benadryl. It can make it worse. So oral, what do you do with oral? When do you recheck? In about 3 weeks of taking the therapies successfully, you want to recheck the ferritin levels. IV iron, you want to check it 1 month after infusion, then maybe every 3 months, and kind of determine if you're going to have to give more infusions. Now, what about IV iron in a patient who's inflammatory or inflammation of chronic disease? What do you have? And they have a low iron state. Now, you never want to give it a septic shock. You never give IV iron in a septic shock, but you can never want to give oral iron because you're not going to absorb it. It's not going to in an inflamed state. So you would consider IV iron. But remember, not in septic shock, not when they're hemodynamically unstable, unless there's some weird thing, as if maybe they're a Jehovah's Witness and they've had a severe bleed and they were hemodynamically unstable. And then at that point, once you get them stabilized, it's consider IV iron therapy to get them repleted.
Thanks for listening. Visit brilliantcourses.com to learn more and claim credits for this educational activity. See you next time.